Okay, so we're going to pick back up on our review with congestive heart failure. Remember that it's just a review. We're hitting some high points. The full meal deal is still on the playlist on the YouTube channel. Okay, so if you need to go back and pick up like the entire class, you can go back in the playlist and pick up the entire class. Let's talk about congestive heart failure. All right. Referring back to the anatomy, we remember that you have a right side pump and a left side pump. And when you talk about CHF, you have to look at the heart on the right side and left side. So you have right side failure and left side failure. So you have to look at it as two separate pumps. CHF can either be acute, or a sudden onset due to primarily an MI. So if someone had a large surface area MI, then that would send the patient into failure because the ventricle can't pump the way it should. And so you would get left-sided failure right away. So you'd get the backup in the pulmonary edema a lot faster than you would in the extremities due to the MI. Now, chronic CHF, which is really the most common kind, typically they will start with right-sided failure. So the right side of the heart's going to fail. Right-sided failure will lead to left-sided failure. So right leads to left. When we talk, and we'll break that down in a minute between right and left-sided failure. First, let's talk about Starling's law. Starling's law is quite complicated. It's more mathematic, but he did break it down into medicine. Thank goodness that we don't have to do the math, okay, in it. But when he talked about congestive heart failure, one thing he did, I call it the rubber band law or the tourniquet law now, since I have this tourniquet, is that Starling said that the heart, those myocardial fibers, will stretch and relax, and when they stretch out, they will come back to their normal shape unless they're overstretched for a long period of time, and then they won't come back to their normal shape. Okay, so we take this tourniquet and we look at it. If you're a visual person, you can look at it and envision my two hands as the heart. So it's going ba-boom, 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 right? This is coming back to its normal shape. And that would be a normal heart. That's our heart when it beats. Ba-boom, 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 right? And it stretches and it relaxes back to its normal shape. Then it stretches and relaxes back to its normal shape. In failure, because the heart is not contracting, you lose contractility is one of the main problems with congestive heart failure. It's not contracting, and also you lose cardiac output due to a decrease in stroke volume. Remember, cardiac output is what?
Stroke volume times heart rate.
Right, stroke volume times heart rate. So in CHF, what happens is instead of this, you get this. You go boom, boom, right? And you can see the hands not coming back together again. This is normal, right? And this is CHF. And so that's sort of the rubber band thing with Starling's law. And that's about as complicated as we get. In it is that those myocardial fibers are so stretched out that they won't come back. Just like a rubber band when it gets stretched out. It's like your sweatpants. You get stretched out, that elastic gets stretched out in it, they don't come back to normal. So they fall off, right? And so that's what sort of this is here with in Starling's law. So let's look at these signs and symptoms. Mild to severe confusion. That's due to hypoxia, right? So you have someone that has maybe left-sided failure where their lungs are full. You get some hypoxia with that. Anxiety because they can't breathe. I don't know if you've ever been into a situation where you have trouble breathing, but when you can't breathe, it does create quite a bit of anxiety because of the workload of the heart, the potential fluid that's in the lungs, and then you get the heart is sort of enlarged, okay? And so it's having to work harder. You get an increase in respiration, dyspnea with shortness of breath, sort of an increase in work and breathing as well. And this sort of, especially in like a test question or even in real life, this is what you see. These patients with CHF, whether acute or chronic, they can't lay flat. If they have left-sided failure, and left-sided failure is when you have the pulmonary edema, they can't lay flat. It feels like they're drowning. Literally, it feels like they're drowning. I've had patients tell me that I can't lay flat. I feel like I'm underwater. Because when they lay flat, all that fluid that's in their smaller airways go up to their larger airways, and it feels like they're drowning. So they can't lay flat. Most CHF patients sleep at a 45-degree angle. They have all these pillows and everything, and when they go to sleep, they're sleeping at like a semi-Fowler's position. Distended neck veins or jugular vein distension. Remember, you see jugular vein distension when the patient's up at a 45-degree angle. You turn their head, and those jugular veins on the side of their neck, you can see that. They're pronounced where you can see jugular vein distension. That is also a sign of failure because of the fact that we have the inferior vena cava on like right-sided failure where the blood backs up into the inferior vena cava, creating peripheral edema. Then in the superior vena cava, it backs up, causing jugular vein distension. Due to the increase in respiration, you have an increase in heart rate. So increase in respiration, the heart rate is going to go up. Plus the heart is trying to compensate for the loss of contractility or loss of cardiac output. Pressures don't really vary, just experience-based. I've seen more hypertension than normal blood pressure, so they're normally hypertension. You get this abdominal distension. That's called ascites. It's like A-S-C-I-T-E-S, ascites. And it's where the abdominal cavity, it looks like a melon almost. It's nice and round, it's not like a, big old bluebell belly there that just sits there and flops. It's sort of rounded because it's full of fluid.
Like a pregnant belly, kind of?
Almost, yeah, like a pregnancy. But it's super tender to palpation because it's fluid. What this patient's doing is they're third spacing this fluid, and this fluid is third spacing out into the abdomen and causing this abdominal distension or ascites. It's very, very painful for the patient. And then you have extremity edema, fluid in the lower extremities. Okay, edema in the extremities is due to right-sided failure. So when the right side of the heart begins to fail, that's probably not a good term, but when they sort of get into right-sided failure, okay, you get back up in the vena cavas, which is going to cause back up into the extremities, into the lower extremities because of gravity. But I've actually seen it in the hands before, okay, but due to gravity, mainly you get it into the lower extremities. So these are some of the signs and symptoms of congestive heart failure. So shortness of breath, anxiety, diaphoresis or sweating, tripoding. Remember, tripod is where they're in that position where they're trying to open up their chest cavity a little bit more. They're bent over, even sitting up, they're sort of bent over, and they tripod. So like if I had one leg and two arms, right, I'm tripoding out. It opens up that cavity to try to get, it decreases the pressure in the cavity and tries to get more air in. Okay. Those are also signs and symptoms. Pulse, edema, we've talked about that in the lower extremities, jugular vein distension. Very late cyanosis, I don't want to get too close. This thing jacks up when you touch it. Very close. Very late sign, cyanosis. Cyanosis is always a late sign. You start out with peripheral cyanosis in the fingernail beds, in the mucous membranes of the lips, inside of the lips, and then as it worsens, very much worse, you get central cyanosis, where you start seeing cyanosis in the chest cavity and in the face. And then the confusion, like we said, is from some hypoxia, which we can correct, right, with oxygen, or we can start to correct. What's very common with congestive heart failure patients, DM or diabetes, hypertension, they're in this cardiac rhythm most of the time, atrial fibrillation, which, like it says, the hypertension increases the risk of stroke in the CHF patient, but they're in a rhythm called atrial fibrillation. If we go back to our EKG recognition, atrial fibrillation is always irregular. So that patient, that CHF patient, will have an irregular pulse. Okay, that's common. That's common in CHF. And then if you were to hook them to a cardiac monitor, you would see the atrial fib. Atrial fib is an irregular rhythm with no discernible P waves. So it's in between the QRS complexes. It looks like ventricular fibrillation, right? But this is atrial fibrillation because it's not VFib because you have QRS complexes. So you have atrial fibrillation, irregular rhythm with no discernible P waves. And then in left-sided failure, what happens is in the pulmonary vessels, when the left side of the heart fails, it starts backing up into the airways. It'll start in the pulmonary capillaries. Okay, that study of that we won't get into here is called capillary dynamics. It increases the pressure in those pulmonary capillaries, and we know that when the pressure increases, air and fluid is going to move to where the pressure is lower, correct? And so what happens is it moves out of those pulmonary capillaries into the alveolus, and now you have fluid. The biggest problem with this, and that we'll pick up in a minute, is you get a V as in Victor, Q mismatch, ventilation to perfusion mismatch, because the fact that the patient's breathing in air, but they can't diffuse the air because now there's fluid in the alveolus, and the air is trapped in there. It can't get through. There is a thin layer of fluid between the alveolus and the pulmonary capillary, but it's not that thick where it doesn't naturally diffuse across. Here we have a diffusion problem where the air can't diffuse through that fluid, and as the fluid fills that air sac, it only gets worse. Okay? We're thankful that we have a gazillion of them, okay, or this CHF patient is, that way they can breathe. So we have a lot, but that fluid will start to, in left-sided failure, that fluid will begin to creep into the airways. And then back to the frothy edema, it reminds me so much of the froth that's on the top of your lattes. From Starbucks, you take that off, and that's got froth on the top. CHF. The problem with it is, with this, and this is coming out of an endotracheal tube, but otherwise out of their mouth, we get that in the signs and symptoms. Back then we saw that pink sputum. So the pink is from a mixture of blood that's coming from the capillaries, but you get this frothy sputum coming out of the patient's mouth. That's an airway problem, right? So we're going to have to suction that before, if the patient needs positive pressure ventilation, we're going to have to suction that sputum out, either endotracheal or oral suctioning. We're going to have to suction that out. If you do positive pressure ventilation it's just going to blow it back down to the airways. So the frothy sputum, your latte, top of your latte becomes an airway problem. And then on right-sided failure, you get the cankles. Remember, you get this edema that builds up. And as you can see in this person's feet and up into their ankles and calves and stuff, they have this edema. One of the biggest problems with this is perfusion or circulation. They're not getting very much circulation, so as you in your assessment check a dorsal-pedal pulse, it may not be palpable. Oh, got that big word out. Okay, good. It may not be palpable. You may have to do a Doppler there to get a pulse. The other problem is that it is painful for the patient. That edema and swelling is painful for the patient, and definitely painful for them to walk. We get with this some pitting edema, and so what takes place is in pitting edema, the patient has that swelling or those cankles, and we want to determine the depth or the severity of the edema. So we push in, and it makes a little pit there, almost like a 60-degree wedge would make, right? It makes a little pit, a little divot there, and we push in, and pitting edema is measured in either +1 to +4. I don't think they really measure it past +4, but it's measured in millimeters. So when we push in on a little pit, if we want to measure the pitting edema, then we would measure that in millimeters. Right? And then that just tells us the severity of the edema. I've pushed in and measured this on patients, and that pit has lasted our whole transport, like 15, 20 minutes. It's still, pushed in. +1 edema, you push it in, and it's going to refill back in pretty quick. +4 edema could stick around for some time. Okay, so let's talk about assessment or treatment. You do your complete assessment, do your good sample, your OPQRST, get good vital signs, all that's across the board for every patient, right? We want to set the patient upright. We want to oxygenate the patient. We do evaluate the need for oxygen, but I'm telling you that this patient, left-sided failure, is going to need oxygen, whether their SpO2 is below 94% or that they're having outward signs of respiratory distress. So we're going to provide oxygen. We may have to provide positive pressure ventilation or the bag valve mask. We may have to start bagging the patient depending on their oxygen need, or CPAP, right? We can use CPAP for these patients as well. Okay, so the other treatment that we look at, and this is sort of outside, so besides positioning and oxygenating the patient, on the EMT side, that's about as far as we can go. Okay? On the ALS side, paramedic side, on up, we can start giving them medications. So what this patient's going to need is a diuretic, where they're going to try to start removing that fluid with the use of the kidneys. So they're going to diurese. You give a diuretic for a patient, you need to make sure that they can use the bathroom, because within just a few minutes, they're going to really have the urge to go to the bathroom, to urinate, because they're diuresing. We can pull this fluid off. On some patients that have really bad pulmonary edema, they will go in, they will place a chest tube, and they will remove the fluid with the chest tube. Okay? There's a problem with contractility with these patients, so they may have to give them a medicine, IV medicine, IV drip medicine on this more severe case, like dobutamine. With dobutamine, one of its functions is that it increases contractility. And these patients are going to take these same medications. So these patients are going to take a diuretic. They're probably going to take medicine for hypertension. They're going to take medicine for contractility, like digoxin, which increases contractility. So they're going to take these medicines daily to help. They may even take potassium too. Depends on their diuretic. Some diuretics are non-sparing, potassium sparing. So with the fluid goes the potassium. So they have to make that up. They have to take potassium. So you'll see a number of different medications with this patient as well. Mainly, once you remove the fluid, and get that under control, it's airway support. But they're always going to need to be positioned, okay? When in this congestive heart failure patient, we won't go over this because this is like a lot of information, but the two major airway sounds that you're going to hear is rails. If you live up north, if you're a Yankee, it's rawls, right? But since we live in Texas, it's rails. Rails or crackles. And crackles is fluid in the small airways. The best way that you can, besides listening to it in a patient, that you can understand what crackles sound like is open up a carbonated beverage like a canned Coke, take your stethoscope and place the diaphragm of the stethoscope over the top of your soda. Don't touch it so you can go ahead and drink it, right? But place the stethoscope over the top and you hear those bubbles because that's a gas, right? CO2 moving through your soda just the same way with air in the lungs moving through that fluid. So it's very much the same and it sounds the same. And sort of train your ears on how to listen to crackles. Rhonchi, on the other hand, is fluid in the larger airway. So crackles is fluid, air moving through fluid in the smaller airways. Rhonchi is fluid moving through fluid in the larger airways. And the way that you can train your ear for crackles is that you can have your soda with the straw in it. You get that big straw like from Whataburger, right? The big orange one. And then I'm sure that you've done this before. And as a younger child, right? Is that you blow air into that straw, into the fluid, and you get that bubbly sound, right? And so that's the same thing. That's sort of like rhonchi. Right. So you have rails, crackles, those are the same, or rhonchi. Like I said, the diuretics, a beta blocker, they may give a beta blocker to help with the heart, to slow the heart rate down. This ACE inhibitor, angioconverting enzyme inhibitor, what the ACE does is it works with the RAAS, the renin angiotensin aldosterone system. Okay, and that is the way that RAAS is how the body controls the blood pressure on a longer term. Okay, so the RAAS system is designed to increase the blood pressure when in someone that's their blood pressure's dropping or they get hypotensive, okay, for a longer period of time. ACE inhibitor is going to inhibit this RAAS, okay, to decrease the blood pressure. Another medication that we might give too, not in EMT land, but we give nitroglycerin sublingual. We give that. Not only does it drop the blood pressure, but it vasodilates and it allows that blood to flow a little bit better. Like I said, we give digoxin, and it's a very small dose. It's 0.2 milligrams, or dobutamine, like in the ICU with the IV drip. These medications are positive inotropic medications. You have three different things there, three different words. You have inotropic, and positive inotropic medication increases the force of contraction. And that's what digoxin and dobutamine do. All right? You have dromotropic, like a drome, right? Dromotropic, which increases the rate of conduction through the AV node. Okay, just take that for what it is. Okay? And then you have chronotropic, which increases the rate. Okay, so, but in CHF, we're talking about inotropic, increasing the force of contraction. I guess I can just go over this part here too. Okay, with pulses, because it's a good part of the review. A normal pulse, when we check a normal pulse, okay, a normal pulse is a +2. So when you press down on your radial pulse, okay, you want to press down, and it's hard to describe, but I put it like you're holding hands with your girlfriend or boyfriend, right? And you don't want to squeeze their hand or push down too hard. It's a sort of a gentle sort of push. So when you check the radial pulse, you push down, okay? And you push down on that, and you feel the pulsation. And when you push down, you can almost sort of stop the pulsation like a tourniquet effect, but you can't quite, okay? That's a +2. The more time you get experience checking pulses, this will make better sense. A weak pulse is a +1. So when you push down, you do stop the pulsation. So when you push down on that, the pulsation stops. A weak pulse is a vascular problem, cardiovascular problem. The heart, it's not pumping very hard because you can stop that pulsation. A bounding pulse, or a +3, when you push down on that in the same method, you can't stop it. I mean, you can push it like you're holding your back to the you're holding your hand with your boyfriend or girlfriend, and they run the red light, and you squeeze. So I mean, and you're like, right? And so, and you can push down hard. But that bounding pulse, you can't stop the pulsation. Your finger just sort of bounds off. This is telling you that the heart is working hard, okay? Or that you are well caffeinated, maybe with that energy drink or whatever, right? You got your pre-workout going. Good. You get that bounding pulse. It's really working hard. Any questions there? Are we okay? All right. An aortic aneurysm it's almost, I describe it as, on a tire. You get that bubble on the side of the tire. With the tire, you have multiple layers. In the same way with the vessel, you have multiple layers of the vessel. Right? We have the lumen, which is the middle, then the tunica intima, which is the inside layer, and the tunica media. Is that the way you say that? Tunica media, okay. At the middle, and the tunica external on the outside. Well, what happens in aneurysm is that tunica intima and that tunica media separate, and then blood sort of flows in that separation and creates a bubble in the artery. You can have, and of course, this is the aortic aneurysm, so it's probably anywhere from the curve of the aorta into the abdominal, where you would have an abdominal aortic aneurysm. You can tell these aneurysms, abdominal aortic aneurysms, are usually the most popular, okay, besides cerebral aneurysms, because of a palpating mass. So when you push in, when you're doing your assessment and you push in and you have a pulsating mass, that's a sign that they have an abdominal aortic aneurysm. We want to identify these and correct them through the surgical process before they rupture. Like if an abdominal aortic aneurysm ruptures, it depends on the size of the aneurysm, but I've literally been standing on the side of the patient that had an aortic tear and went into the OR with them doing CPR, and the thoracic surgeon and the abdominal surgeon were right there with me, and the patient still bled out. We were there, they knew it, got coded, we went into the OR just like on TV, and they still couldn't save them because the vessels are under high pressure. Okay? But you can have the same aneurysm in the head, the base of the skull, like at the circle Willis, and you'll get dizziness and headaches, unexplained dizziness and headaches at first. And if those aneurysms rupture, it is also life-threatening. An aortic dissection is a little bit different. This will become an aneurysm because the blood flow will continue to flow into that dissection. Okay, but the sign is a little bit different. It has a very unique sign. This aortic dissection, it feels like someone is ripping their abdomen apart. So the patient will sit there and say, "It feels like the Hulk is ripping me in two. I'm being pulled in two in the abdomen." That's sort of the classic signs. There's more to it. I don't think we have them on here, no. There's more to those signs than that. But those are the two major. So the abdominal aortic aneurysm, you get a pulsating mass. In this aortic dissection, you get to where it feels like someone is pulling the patient apart. They both need surgery. Some people live with aneurysms either because the aneurysm is too large to repair or that the patient is not healthy enough to go into surgery to repair the aneurysm. All right. Questions there? That took longer than I thought, so we're not going to be able to get into the other respiratory stuff right now. But we'll pick up, when we pick up, we'll start with COPDs, emphysema, bronchitis, asthma. Okay, but that's for another time. Any questions? You guys good?